Good afternoon and welcome to the continuing series of our 2018 Brown Bag webinar. We're so happy to have you join us. My name is Joan Williamson. I'm the Director of the Virginia Patient Safety Organization, and on behalf of the Virginia Hospital and Healthcare Association Center for Healthcare Excellence, I'm happy to welcome you to our Brown Bag webinar series. This webinar is a series featuring Virginia hospital strategies in promoting safety culture and high reliability. I wanted to go over a couple housekeeping task items for you before we get started in today's webinar. Slides were sent out this morning. If you didn't receive a slide, please let us know and we'll be happy to send them to you after the webinar. This webinar is being recorded and will be posted on the VHHA Center for Healthcare Excellence website. We recommend listening by phone. We have found that to be the more reliable way to listen. To join over the phone, just select telephone in the audio pane, and the dial-in information will be displayed for you. You will have the opportunity to submit text questions to today's presenter by typing your questions into the question pane on the control panel. You may send in your questions at any time during the presentation. We'll collect these questions and address them during the Q&A session at the end of today's presentation. I'd now like to introduce today's presenters from Southside Regional Medical Center, Brenda Woodcock, the Chief Nursing Officer, and Diana Willman, the Director of Pharmacy. Their presentation is IV Dilaudid, Less is More. And so, Brenda and Diana, welcome, and it's all yours.
Thank you very much. Good afternoon, everyone. This is Brenda Woodcock, the Chief Nursing Officer at Southside Regional Medical Center. I'm here joined with Diana Willman, the Director of Pharmacy. And I'd like to start off by telling you a little bit about our facility at Southside Regional Medical Center. Southside Regional Medical Center is in Petersburg, Virginia. We have 300 licensed beds. We have specialty services in all sorts of different areas: bariatrics, cardiology, oncology, and total joint and spine. We serve the Tri-City area, and in fact, we are the sole provider of many specialty services in the Tri-Cities, such as our Level 3 Trauma Center with over 60,000 emergency department visits a year. And in fact, we are in the process now of building a freestanding emergency department to better serve our community in Colonial Heights. We also have invasive cardiology, and we have a lot of patients that come here from the field and from other facilities for STEMIs. We are a primary stroke center. We have radiation oncology services, and we are the only labor and delivery unit in the Tri-City area with a Level 2 NICU. We're very proud of all of our services that we offer. In fact, we have certifications and accreditations in a lot of our specialty areas, including bariatrics. We are certified as a primary stroke center. We are accredited as a chest pain center. In fact, we were the second in Virginia for our cath lab certification. We also have Joint Commission seal of approval for our hip and knee joint replacement program, and we are accredited for our cancer center as well. So this safety initiative that we have that we implemented here at Southside, we're going to go through some objectives with you today to walk you through this initiative. What we're going to do is we're going to talk about the safety concerns with IV hydromorphone at our facility. We're also going to discuss how we implemented the usage guidelines at SRMC. We're going to talk about the impact on prescribing and adverse events. And we're going to also talk about our future opportunities for a wider safety net and what this has really led to in this safety initiative. So how did this safety initiative start off? It really was a combination of different approaches. We currently today have rapid response meetings and we review rapid response data. We want to know what led to the rapid response, what were the outcomes, and really drill down into that information. We also look at trigger reports, and what that is essentially it's antidotes that may have been used for different types of medication, reversal agents. And so one example of an antidote might be Narcan. We also look at adverse drug reactions, and we look at severity levels around adverse drug reactions. What occurred? What level of severity of reaction did occur? And what were the outcomes related to that? So all of these things, we started to really drill down on some data, and as a result, we saw a commonality amongst all of these reports, and that was IV Dilaudid. And so now I'm going to turn it over to my colleague, Diana Willman, the Director of Pharmacy, who's going to walk you through the steps that were used in this safety initiative.
Thank you, Brenda. So the first thing that we noticed when we realized that we had an issue with IV Dilaudid is there were multiple safety concerns that emerged. One thing was that we noticed a lot of high doses and high frequencies on our physicians' order sets. And when they're built into an order set, they're more likely to reoccur because they can be ordered on a consistent basis in that manner. We were seeing 2 milligrams, 3, 4, even 5 milligram doses of hydromorphone. We also noticed that there was a peak effect that could be harming our patients from a high dose, but also the dose might not be very, very high, but also might be given at a higher frequency so that the doses were more likely to stack up on each other before the previous dose was cleared. We saw a concerning trend, which included adverse events in younger patients. We even had an event in a 20-year-old, so that was not our typical elderly, patient that's opioid sensitive. It was younger patients as well. We also interviewed our staff and our physicians, and we realized that we had some education opportunities with regards to potency. A lot of staff could say, I know that hydromorphone is powerful, but they could not actually articulate that the ratio was 1 milligram to 7 milligrams of morphine. There was also some education opportunities with regards to risk factors for oversedation, and also when benzos are combined with the opioid, that causes an additive effect. And we also saw that inconsistent monitoring was in place. Only our PCAs received constant pulse ox monitoring because that was our current policy. But as far as IV push doses, there was not a lot of consistency with regards to the monitoring. So we knew that we had to make some changes. We decided to get all of our data together. Our clinical manager did a tremendous amount of work compiling all of these events, looking at what the factors were involved in each of those. We've brought data from ISMP, our personal events of harm, as well as our prescribing data. We pulled usage reports from Cerner and realized what types of orders were being placed by our prescribers. We actually brought all of that information and decided to meet with some of our key medical staff leaders. We pulled together our surgery chief, our ED chief, internal medicine chief, and our anesthesia chief, as well as our quality and risk department and pharmacy and nursing. We explained all of the events to them and said, we need your help in deciding what is reasonable, but what is also safe for our patients. We developed some guidelines for use together with them, and then we took those to the committees for approval. We went to P&T, performance improvement, med exec, and even our quarterly medical staff meeting. We came up with our education plan as how we were going to roll this out to the pharmacists and nurses and the staff throughout the hospital, and then we developed a letter to the medical staff explaining the changes that we would like to put into place to make the usage of IV hydromorphone a much safer process at our facility, and also how we intended to monitor our patients better. So a letter went out at the end of July last year, and it was signed by our chief of staff, as well as Brenda and myself, and it basically described how we ended up here, what we plan to do, and what our proposed new safe usage guidelines for hydromorphone at Southside Regional would include. And this flyer on the right shows what the education flyer went out for all of the staff. As you can see very prominently, we focused on the potency, 1 to 7. And then we also had other recommendations that needed to go into effect immediately for patient safety. One of the most important things is we called for much lower starting doses on our hydromorphone. We should not be starting patients who are opiate naive out on a 2 milligram Q2 regimen of this medication. So we educated and we We said the usual starting dose for this actually is 0.2 to 0.5 for most patients. So we called for that change, as well as a longer frequency between doses. In fact, we even got the pharmacist involved, and the pharmacist was charged with calling for any order that was above 1 milligram or more frequent than every 4 hours, to at least have a conversation as to why a particular patient might need a different regimen. We also involved our respiratory department and got them involved in terms of monitoring, and we came up with a requirement for 100% of pulse ox monitoring on all of our IV hydromorphone patients. We also outlawed, so to speak, but we said that no doses above 2 milligrams at our facility would be available in terms of stocking in Pyxis, and also not recommended on order sets or for patients who were in our care. So we're going to take a look at how the action plan impacted prescribing in our facility. The first thing we saw was a overall reduction in Dilaudid utilization. We'll look at some graphs here in a second. We saw a greater interval between doses being used. So where we were previously seeing an every 3 or every 2 hour regimen, now we are seeing much fewer orders in that frequency range and much more of the every 4 or even longer. We didn't have any hourly regimens after our interventions, and again, the overall utilization was down. And then we'll go to the next graph here and take a look. As far as all of our IV Dilaudid orders, you can see that the 2 milligram dosages were drastically reduced. There was a 46% reduction in our 2 milligram doses. There was also a 26% reduction in our 1 milligram, and there was an increase in our 0.5. So this is exactly what we would hope to see, is a lowering of those higher starting doses and then a higher utilization of the smaller starting doses. And again, we focused on the orders here. This is not doses administered to the patient by the nurse. This is orders from the prescribers. And we saw a 10% decrease in our overall ordering of Dilaudid. We did have a 4 milligram and a 3 milligram order, actually, so that was somewhat against our policy, but I looked into that. Both of those were from our spine surgeon, and they were both from the same patient, so there was obviously some extenuating circumstances there. As far as the orders for the 2 milligrams, as we saw in the little graph on the first table, there was a 46% reduction in the overall 2 milligram ordering. And then again, the biggest change in the frequency occurred with the 3 hour and the 2 hour doses dropping to single digits. As far as some additional findings, we found that there were no serious adverse events. There was nothing in the level 5 through 8 category, whereas before we had had a number of events in the higher level severity. And we also did not have any reports of inadequate pain control. We did not have prescriber complaints. We even, in our letter, had given the providers an opportunity for feedback within 90 days just to let us know if they felt like this new set of guidelines was working or if they had any suggestions for change or improvement. We did not receive any feedback other than to consider lower doses in Pyxis so that the nurses would not have to waste as much medication. We also took a look at our Narcan utilization, and we also had improvement, as mentioned, in the 100% of IV Dilaudid patients receiving pulse ox monitoring, and also an increased awareness across multiple disciplines, to the point that even our pharmacy technicians were noticing when a 2 milligram dose versus a 1 milligram dose was being utilized. So they were looking at it not from a utilization and inventory standpoint, but they were thinking about the drug differently. We had gone over so much education that they were thinking about this medication in a different way. So this is a look at our ADR trend, and these are just ADRs involving Dilaudid. You can see the before and after, and for facilities that use the NCC MERP classification, these are the E, F, G, H's, and I's. Our system uses numerical classification, but they do correspond to the same levels of harm. You can see that we had some 4s, 5s, and 6s, and after our implementation of the action plan and the education, we dropped those ADRs to only 2 in the level 4 category. As far as our Narcan utilization, Brenda and I actually debated on whether to include this slide because we were asking ourselves, what does this demonstrate? What we do see is that Narcan utilization was down in the from the before to the after period. There was a 36% reduction in the ED utilization. Now, granted, those are from patients coming in from the outside, so they don't necessarily reflect what's happening in our hospital. And we thought that may be due to more Narcan availability in the community. Fewer patients are reaching our ED needing that medication. That's speculation. We're not sure if that's the case or not. As far as the rest of the units, there was an increase in our med-surg area as well as PACU, and that could be a possible increase in staff awareness, whereas in the past, Narcan may not have been immediately thought of. Now staff are actually thinking, our nurses are assessing the patient and thinking that perhaps Narcan may help this patient if they are, they seem to be having some sort of oversedation. So in all, our lessons learned were that less truly is more. We, as we demonstrated, have seen a decrease in the prescribing of higher doses, but without an increase in patient pain or provider concerns or anything to that effect, and our ADRs are down. We also learned that we could not assume that our providers and our nurses and our staff could articulate the potency of this medication, so we had to educate everyone in the same way and get everybody on the same page. As far as our physician leadership, the engagement early on proved to be very valuable, so that if we had any concerns, we knew that the chiefs of those key departments had already been involved in the decision making, and therefore we all had a unified front, even with, as mentioned, respiratory being involved, nursing, pharmacy, and key physician leadership. So we had a unified front on our initiative. One thing that respiratory learned was that they needed some way to know who was on IV hydromorphone. So they actually had a report developed through Cerner, and I believe our quality manager set that up, quality director, so that they could get a report every shift of all patients who were on IV hydromorphone. And if a patient was started on the medication in the meantime, the nurse could always call them and let them know that a patient needed to be set up with pulse oximetry. We also, as mentioned, supplied lower dosages in Pyxis, and we were making sure that our electronic record order sets and the products available all match. We also know, as I'm sure all of the facilities on this call know, that shortages have been a tremendous factor, especially of late with the opioid supply chain. So we can only speculate, but our usage of hydromorphone may have been even lower if the morphine availability at our facility had been at its usual levels. So as you're listening to what we had put into place, we realized there's an opioid safety continuum, and there's facilities who may have tackled these issues 5 or 10 years ago. And Brenda and I have worked at other facilities where we have seen these changes put into place early on, but there's other facilities who've yet to tackle this. There might not be any sort of usage guidelines in place, or the facilities may not even realize that IV hydromorphone is contributing to any sort of patient harm. We're somewhat in the middle on our journey. We do have some guidelines in place and some increased staff awareness, and we definitely have some additional things that we would like to work on. But just ask yourself, where is your facility on this spectrum, and what else can be done? Keep having the conversation and ensure that there's a sustained effect from our patient safety initiative. So as far as what we would like to continue to work on at Southside Regional, we definitely would like to limit the duration of IV opioids. We are getting ready to put into place a 72-hour hard stop on all IV doses, including all opioids that are injectable, as well as our PCAs. So that will go into place very soon. It's already been approved by the medical staff. This initiative with hydromorphone and patient data has caused us to also take a look at additional practices in our facility, such as lorazepam for sedation and other things that we would like to tackle in terms of patient safety. We also want to continue educating our staff, but also making changes in our patients' expectations so that they are aware of the safety initiatives that we have in place and that their expectations are realistic for their safe care. We'll continue to monitor our ADR data and make sure that hydromorphone continues to be utilized safely at our facility, and we'll also watch for any new trends or any unexpected issues that we may not have been previously aware of. And that is it. We will take any questions if you have any.
Thank you, Brenda and Diana. That was a great presentation. And it was great to walk through the process improvement that you all did. Again, if you have questions, you can type it into the chat box on your toolbar, and we would be happy to relay those questions to Diana and Brenda. As we're waiting for questions to come in, I do have one question. And were there any specific barriers that you had in rolling out your improvement process? And if so, how did you address those barriers?
This is Brenda. I will be honest with you. We anticipated that the medical staff would be a barrier, but honestly, that was a surprise. And I think the reason why is if you utilize your data and you're prepared in what you're presenting and you let patient care and safety drive your initiatives and what you're working on, then that tells the story for itself. And I think that's really one of the barriers that we did overcome because of we had the data to support what we were asking for. And we learned very quickly to get those department heads in support of this so that they could help drive the rest of the medical staff in this direction. So that was actually a surprise. I think the barriers were really minimal. I think that I also anticipated that nursing might be a barrier, quite frankly, because of course they want to keep patients pain-free, and you know they are there to advocate for their patients and to help in this manner. But what we've done as a result of this is really changed the thinking of a lot of people, not just about Dilaudid, but about pain medicine in general. And I think it's really been eye-opening for us in many different areas.
We have a couple questions coming in now, and one question is, are you providing any patient education?
Well, actually, we just put together a letter for patients that talk about some of the opioid shortage, but also in the letter, it really gave us an opportunity to educate patients on other modalities for pain control. So that is something we just started, we introduced a couple weeks ago, and we're putting it into the patient admission packet for nurses to review that upon admission, patient admission.
Great. We have some more questions coming in. One question is, how long did it take for your before data and your after data, your improvement? How long did that take?
The before data was actually just a snapshot that we took as we were getting our data together to go meet with the medical staff. So that was a September 1st of 2016, actually, till March 31 of 2017. So that was about a 7-month period of time. And then we took that data with us when we met with the medical staff. And then once we sent the letter out, that was July 26th of this past year. And the after data picks up right at August 1st. So it includes almost days after the letter went out until the other day. I think the 14th was when I had to end the data so that we could actually make the slides for the program.
Thank you.
And I hope that answers the question.
I don't see any other questions coming in. We'll give one more minute and see if folks want to have any more questions. This was just a great presentation. It was great. It was very practical and was very clear. We have another question coming in. Nope, we're just saying, people are saying thanks. They appreciated the presentation.
We appreciate
well, there are
more
questions coming in. we may be able to give people back a few minutes of their day, 5 minutes of their day. And again, to the Southside Regional Medical Center team, Brenda Woodcock and Diana Willman, we just really appreciate your presentation. This will be, this has been recorded and will be posted on the VHHA Center for Healthcare Excellence website, and we'll also then send out a recording link to our participants as well. Thank you so much, and enjoy the rest of your day.
Thank you.
Thank you very much.